Good evening, sir.
Right.
Hello, good evening.
Manogar sir, good evening. Good evening, sir.
Dr. Somo.
Dr. Madhubala, Manogar sir also joined. Narmada, yeah.
Sir, good evening, Manohar sir.
Dr. Jagdish, good evening.
Good evening,
Great
sir.
man.
Good evening, sir.
Yeah.
Sir.
Hello, Dr. Vivek. Good evening.
Sir, good evening,
Vichu,
sir.
Vichu, good evening.
Good evening, sir. Good
Can
evening.
we start?
Just
Yes,
wait.
Dr.
Good
Narmada.
Good evening, sir.
Good evening. Somo, very colorful. Very colorful.
Sir, thank you, sir.
Our daily
Thank you, sir. I think
color.
இல்ல sir.
சோம்ஸ் பாஸ் நீங்க கண்ணி பண்ணுங்க ஓகேவா
Sir,
வெளில
it's done,
வந்துடுறேன்
done. Okay, thank
லைவ்ல
you.
போட்டோம்
Thank you.
ஓகே பை
You,
ஆல் தி
yeah,
பெஸ்ட்
yeah,
Thiru.
sir. Thank you.
All the best.
Thank you.
யா
Thank you.
குட்
Yeah.
ஈவினிங் சார் குட் ஈவினிங் சார் குட்
Thiru, good evening.
ஈவினிங்
Sir,
சார் குட் ஈவினிங் சார் ஏர்போர்ட்ல
Naveen,
இருக்கேன் சார் அதான் சார் ஐம் ஜஸ்ட்
Okay,
கமிங் அவுட்
okay, okay. Right.
ஓகே சார்
Naveen sir, I'll make you the co-host so that you can join. Okay, yeah.
Welcome, Dr. Vivekanand.
Good evening, madam.
Good evening.
Thank you.
So I have made Madhubala, Vivek, and Naveen sir as the co-host. Can start, Narmada?
Yeah. No, sure.
Others have joined. Dr. Nimmi Joseph has joined. Dr. Kanimurthy.
All the experts, the panelists and the speakers have joined, sir.
Oh,
Dr.
excellent.
Jagadish is there,
Yeah.
and the Dr. Subbu is also there. So
Should we wait for
people
another
related to child development are all there, sir, and it's almost 8:02. We can start, sir. So once we finish it will be 8:06 when we finish the initial
Yeah.
talk.
Okay. Okay.
A very good evening to all the delegates who have joined on the platform today. It's indeed a great pleasure to have you all here and also special invitees from Kerala, Dr. Naveen and Dr. Nimmi Joseph.
Narmada, voice is very low.
Okay, sorry. Yeah. Are you able to hear now?
Yeah.
Better. Yeah.
We have installation of IAP Ramanathapuram, so our treasurer is not able to join. So we'll start with the pediatrician's prayer. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding to change the things we can, retain the good and accept within reasons the things we cannot change. Grant us your blessings, grace and mercy in all situations, at all time and amidst all people. Thank you so much. So this is a very important second event of IAP Tamil Nadu State Chapter, our specialty series. After infectious disease, we are having the growth and development chapter CME. Now
Again, the voice became low.
now Dr. Somasundram, President IAP TNSC, to do the honors and open the CME program.
Yeah, thank you, Dr. Narmada. So, respected dignitaries on this platform, the chairperson of the GBDP chapter, Dr. Jagadish, the secretary, Dr. Madhubala, the EB member, Dr. Kanimuli. I think Kanimuli is the EB member, right? Sorry. Yes. Okay, and the IAP TNSC office bearers, Dr. Narmada, the secretary, Dr. Rajkumar joined in between. So Dr. Rajkumar, the treasurer, our vice president, Dr. MS Vishwanathan, our academic coordinator, Dr. TN Manohar, and we have our past president, Dr. Venkateshwaran sir, who has joined here on this platform. And our expert speakers for today, Dr. Naveen Jain from KIMS Trivandrum and Dr. VV Vivekanand from Chennai. So they have also joined. And the other experts for this panel discussion, Dr. Nimmi Joseph from Trichure and Dr. Rini Benson from Chennai, and as I told, Dr. Madhubala and Kanimudi are also here for this GBDP. So you all know that the last Sunday of every month is being allotted by IAP TNSC for the subspecialties. So every month, solely with the tagline, ஒவ்வொரு மாதமும் ஒரு சிறப்பு. So this சிறப்பு is today. சிறப்பு is the subspecialty of growth, development and behavioral pediatrics chapter. Last month we have the ID chapter. So I believe we have almost 10 chapters functioning under which have the state branches which were created during the previous years, and so this year also we will try to do two chapters. One is the medico-legal chapter and one is the IYCF chapter. So these two chapters we will add on this year, probably, if things are going on good. And so this month the growth and GDPP chapter will be doing the specialty CME. So wish the GBDP chapter CME a grand success, and over to Dr. Narmada.
Thank you so much, Dr. Somasundaram, for the introduction about this program. Now I request our Academy of Pediatric Science Coordinator, Dr. Manohar sir, to say a few words.
Good evening, friends. Every parent wants their child to be the best in all spheres of life. So it is the primary duty of every pediatrician to monitor growth and development and give guidance for parents for behavioral issues. Early identification of growth and development and behavioral issues are necessary to optimize long-term good development and behavioral outcomes. Hence, today's CME is of utmost importance to all pediatricians, and to share their knowledge and wisdom, today we have multiple experts in these fields. Let us hear from them and get benefited. Thank you.
Thank you so much, Dr. Manohar sir. I request Dr. M.S. Vishwanathan, our Vice President, to say a few words.
Good evening, everyone. Thank you very much. And I think the second subspecialty CME is IDB GB, it's a growth development behavioral pediatrics chapter today. As greetings to our President, Dr. Somasundaram, our academic convener, Dr. Manohar, Secretary, Dr. Narmada, and all others, and all the faculty today. And thank you very much. Please go ahead. Thank you.
Thank you. So I now hand over the session to Dr. Jagdish Kumar and Dr. Madhubala, the Secretary and the Chairperson and Secretary of GDBCon, to continue with the rest of the program. Over to you both. Jagdish sir and Madhubala.
Yes, ma'am.
Yeah, Dr. Madhubala, you can take over and
Take over.
Yes, ma'am. Yes, sir. Good evening, everyone. We now move into the first session of today's program, a highly insightful case-based lecture. This session will feature two important topics presented by our esteemed speakers and will be moderated by our chairperson. It is my honor to introduce our chairperson for this session, Dr. Jagdish Kumar. He is a chief pediatrician at the District Early Intervention Center, Government Medical College Hospital, Tiruvallur, serving in government sector for the past 25 years. He is the chairperson of GDBP Tamil Nadu chapter. He has extensive experience in pediatric care with strong focus on early identification and intervention of developmental delays, neurodevelopmental disorders, and childhood disabilities. Sir has been actively involved in implementing national child health programs and strengthening multidisciplinary services for children with special healthcare needs. He is widely respected for his child-centered approach, commitment to public health service, and contributions to capacity building among healthcare professionals. With remarkable contributions to clinical practice, we are grateful for your presence today. Kindly take over the proceedings, sir.
Thank you, madam, for the nice introduction. Respected teachers, senior doctors, friends and colleagues, good evening to all. First, I would like to thank Indian Academy of Pediatrics, Tamil Nadu and Pondicherry State Branch, President Dr. Somasundaram sir, Secretary Dr. Narmada Madam, Rajkumar sir, Treasurer, and our academic coordinator, Dr. Manohar sir, and Vice President M.S. Vishwanathan sir, for giving me the opportunity to chair this session today. And in this instance, I'd like to thank our senior former DMS sir, Mohan sir, and Dr. Vijayaraj sir also or the one to posted me as DAC pediatrician once when the DAC concept was introduced in our Tamil Nadu. And without wasting our time, we start the session. Today we have two eminent speakers, Professor Naveen Jain sir and Dr. Vivekanandan sir. So talk about two important topics. So over to you, madam. We can start the session with Dr. Naveen Jain sir.
Hello.
So yes, sir. I welcome Dr. Naveen Jain, sir. Actually, sir finished his DM neonatology and PGD epidemiology and research ethics, and he is a senior consultant at Kim's Health Trivandrum and editor of Cloharty Manual of Newborn Care SAE, and he is editor dealing with the development of the infant and young child normal and abnormal 11E and best teacher award and national board examiner. Over to you, sir.
Good evening to you, Jagdish sir, and
Thank you, sir.
all our friends from Tamil Nadu. The topic is well apt that how can we probably recognize a child who needs help in the outpatient service, because most of the work should happen as in we see children during our routine work than having to subject them to any special testing. Let me just get my presentation right. So the first slide, I think, is of utmost important in our pediatric practice. We are doing this subconsciously every day, but when we start doing it objectively, by writing down, by asking specifically, we will not miss any functional problem in children. It's not just the milestones of a child and then trying to score his developmental quotient that is important. Finally, what matters is activities of daily living. So whether it is our students who are presenting a case in the examination, or whether it is a pediatrician who is seeing children in the immunization services, or a specialist like Jagdish sir who is facing children in the EIC who have been referred for care, at the end of the day, what matters to the child and to the family is these three aspects. Can this child feed, whether it's milk or food, like another child of his age? Sir mentioned that growth and development are the most important aspects, and this can be possible only if the child gets the right nutrition. And the World Health Organization has expanded the concept of thriving to work and play. So can the child play like other children for the age? And the mother should not find challenges in having the child to sleep. So before we go to any milestones, any formal assessment, all developmental assessment that should happen at every visit the child comes to you, whether it is for vaccination, whether it is for a developmental concern, or for minor or major illness. These three aspects should be there in all notes. I would base my presentation mostly on the work of my teacher, Dr. M.K. Nair, who simplified development assessment for us by the development observation card, or what is known popularly as Child Development Center grading. At 2 months, we want a child to have a social smile. At 4 months, to have head control. 8 months, the child should be able to sit, and at 12 months, the child should be able to stand. This is the same thing. Make sure that if the baby was born early, premature, then you correct for prematurity and calculate the age from expected date of birth. And during these assessments, make sure the child can see and hear well. Professor Illingworth has clearly stated in his book that one of the milestones which we cannot give a discount is the development of social smile by 6 to 8 weeks. With many of the milestones, we try to reassure parents, trying to say that it's okay. If the child has not done what other children do, we will watch after 2 weeks or 1 month. But this is one milestone when there is no concession. At the first vaccination visit, a child should be looking keenly at the mother, like you can see in this picture, and giving a reciprocal smile when the mother speaks to her. If it does not happen, we have to start getting worried whether this is the first signal that there is a developmental delay. Causes may be commonly investigated are hypothyroidism or a visual problem which is not allowing the child to see the mother. Very often what happens if you tell the mother that there is some problem in development, they would change the doctor. They would go to somebody else because this is something they don't want to hear. And therefore, on the immunization card itself, you scribble a note saying that baby has not attained his social smile and I need to see you after 2 weeks. So that even if they go to somebody else, that somebody else would also pay attention to the same information, which is very critical. So 2 months assessment or 6 to 8 weeks assessment, a child should have by now start feeding without choking for about 10 to 15 minutes, should have a space of almost 3 hours before he seeks the next feed, would sleep for maybe 5 to 6 hours at a stretch at night and have short naps after. So if the baby is not able to do the sleep and play patterns, it draws attention to you that there is some problem. A social smile should be there, and one must mark the birth circumference of head as well as at 2 months of age. What if the child doesn't do this? You would follow the child after 2 weeks and sorry that you would follow the child after 2 weeks, and at 2 weeks you want the milestones to improve. So a persistent of an abnormal sign like head circumference not growing or milestone not appearing is of great concern. If a child has a developmental milestone at 6 to 8 weeks not happening, but happens after 2 weeks, this child is better than another one who after 2 weeks of follow-up also does not show a developmental milestone of social smile. Combined signs like a small head, abnormal tone, poor weight gain, in addition to these abnormal social milestone, and in the setting of a risk factor. For example, let us say the child had a severe asphyxia, and that is the reason we are following up the child. This child chokes during feeds, cries all the time, and has sleep issues. This is showing poor adaptation to daily living. Social smile is not attained. So this is developmental signs are not improving, persistence, combination of signs and risk setting. Now this child has very high risk of developmental problem compared to another child who had severe asphyxia, but at 6 weeks the child develops a social smile, and on inquiry the child feeds well, plays well and sleeps okay. This simple tool is far better than finding an anatomic difference in the basal ganglia or plic sign in the MRI. This functional development or social development is more important. Now we go to the next milestone. So for the first milestone at 2 months, whether the child was premature, you correct for prematurity, had hypoglycemic seizures, severe jaundice, or even a normal child who's coming for follow-up, at 6 to 8 weeks, social smile should be there, head should have grown, the child should play, feed, and sleep normally. Now you follow them at 4 months of age, you should have a good head control. Now you can see this one. You can see this child is so keen at looking at the toy presented to him, and head is in midline, straight on the back. This is what should happen at the age of 4 months. But if a child, like in this picture, which is not green, shows the head tilted to one side, like the picture below, or tends to fall forwards or backwards when the child is made to sit, is an early marker that the child may be having tone abnormalities and posture abnormalities, which is nothing but early signs of cerebral palsy. So other early objective signs which are pointing to cerebral palsy, what is also known as general movement assessment, is showing poor quantity and quality of movements. You can see this is a pair of twins who were born at 25 weeks. At 4 months corrected age, we found that one of the twins, you can see the one to the left of your screen, has limited movements, is lying still, whereas the child on the right of your screen is active in quantity and showing various rich movements, hand, legs, trunk, and this is a healthy pattern that the child should show. So quantity and quality of movements is a hallmark of diagnosing cerebral palsy and does not require any special test. So at 4 months of age, most children would either have already rolled over or would be making a significant effort to make rollover. And this can happen only if the ATNR disappears. ATNR is a protective reflex. Although ATNR and Moros disappear by around 1.5 to 2 months of age, if their child comes and mother says this fellow is lazy and is not rolling over, you do a ATNR, it is present, this is definitely abnormal. Or you do a Moros reflex and it is absent, it should have disappeared by 4 months of age. Many times we have been doing Moros in the young age, in the newborn period, the relevance is very little, but a Moros which has not gone away by 1.5 to 2 months, or a ATNR which has not gone off, definitely by 4 months is indicating early cerebral palsy. So if a mother says the child is not trying to roll over, then you just turn the head to one side and see whether he is showing fencing or locking reaction to that side. If the child extends the hand to that side, that means he will not roll over. And this is a bad sign. 4 months is also known as the catching month. A child can catch the source of sound. He can turn towards the source of sound. He can catch with eyes. I can't forget a child who had a skeletal dysplasia with non-functional hands, but he could keenly catch the object with his eyes. So a child can track the object very well. And the child can catch an object placed in his hand, not reach out, but if something is placed in hand, they will have a good grip of that hand. So 4 months is the catching month, where you catch the sign by eyes, catch with sound, and also catch an object in the hand. So you can see the child very keenly looking at a toy that is going to come into his field. You can see it. There is tracking the object which I am showing in this torch, which is not lit actually, but the child is keenly fixing, maintaining, and tracking. This is the best way of vision assessment than just doing a special test. Fixing, maintaining, and tracking. And you can see the key picture on the other side where the child is fixing and maintaining is this one. Hand should be mostly open like on the right side, but a fisted hand which is not being used is a bad sign because hand represents most of the cerebral function. So by 5 months, we should be able to label a child at high risk of cerebral palsy and refer to the DEIC. So they would have lack of head control. The head would be falling to one side, backward or forward, and not sitting up straight. They won't be able to roll over. And if they can't roll over, have head control, you do a ATNR, and more it is persistent, it is worrying. Hand use is poor, and the baby has a small head by now. Combined signs, remember, and hypertonia and hyperreflexia. So the child should roll over and catch objects. So alert, keen child is what you should be seeing with a good head control and trying to roll over by 4 months. So 2 months, a child should feed well, sleep well, and play well, have a good social smile, and head circumference should be tracking. At 4 months, again feed and sleep and should be well. And the child tracks to the sound, holds, catches the object with his eyes and with his ears, has good head control, tries to roll over and shows good quantity and quality of movements. The child is very, very keen and looking at whatever you're doing. By 4 months, you should have done a OE, and if it is not true, especially in NICU babies, you should have done BERA definitely. By 3 to 4 months, you should confirm hearing impairment and plan a hearing aid if it is there, because that is the age by which language development would get delayed if you don't start intervention. By 8 months, the child should be able to sit. Not like this, falling forward, the child should be able to sit straight with a back and head and neck straight and the legs stretched out like this. He should be able to pivot, turn around and play. He is stable and playing. If the child tends to fall back like this, most of us adults would have cerebral palsy. If you made flat on the floor with the legs stretched out, we would either fall backwards or we fold our legs in because we are very stiff. So a cerebral palsy is a disease of stiffness where if the child is made to sit, he can't sit like the green side. He would sit and fall forward, backward, or have his legs folded in. You can see this picture of a mature sitting, and now this child is sitting with a rounded back, and in fact his grandpa has his hands all around him because he's afraid he'll fall down. The child is supporting his sitting with the hands. He tends to tilt his head, and he is not able to frequently play. Whereas you look at the other child, sitting very steady and confident, plays well, no support is required, head control is very good, and the child is not leaning forward like the child on the left of the screen. So if you see a child at 8 to 10 months of age, the child should be able to sit and play well like this and turn around, pivot around, and not tend to fall down. By now, by 9 months, good hand-eye coordination happens and a pincer grasp also starts coming in. An opposite of pincer grasp would be a bad coordination of the functional muscles and the anti-functional muscles. So instead of having a pincer grasp like this, the child tends to keep his hands played out and cannot make a meaningful grip. Do not forget to assess the vision of a child if you are having developmental problems. The RBSK recommends that by 6 to 9 months, a formal refraction should be done for all children. You can see this child, when the specs are there, the child is able to track the objects very well, and he is able to follow what we are trying to do. And the same child in another picture, when the specs has gone away, he was not able to follow at all. He had a power of -6 on both the eyes, and correction with specs allowed the child to learn from the outside world. By 9 months, when you offer an object, the child should keenly reach out to the object and start playing. This reciprocal play, where the child, you can see, is looking at the mother and playing with her, and the child is playing back and mother is playing with the mother, is very important pointer to make an early diagnosis of autism spectrum disorders or social developmental issues. So by 9 months, if the child is not playing, is not having social communication, then there is a problem. So 8 months, the child sits straight, pivots and plays well, and reciprocal play should be demonstrated by 9 to 10 months of age. By 12 months, you can see a child should stand. Very often you will see the child not standing actually, but if he can do this, you can see the child is very functional with his legs. He's able to push a chair around. So when mothers say my child is not standing, I ask them, does he push a chair around like this? If they say yes, then the child is okay. Whereas this child, you can see, needs support of the chair. Otherwise, the child tends to fall backwards. You can see toeing of the feet. The toeing would not be a problem if the child can tiptoe and run around the room. In excitement, many children can do toeing. But this child cannot stand without support, and this toeing is of concern. The child tends to fall backwards, you will see, the minute the support of the chair goes away. And this is an abnormal stand, which is also been graded in the CDC grading. So if the child cannot stand by this age, you're thinking of familial problems like a large head, delay in standing, cerebral palsy, hip disorder, or spine disorders. By this age, the child should say at least one meaningful word. And if it is not there, you think of hearing problems or global developmental delay, and maybe the first pointer to autism spectrum disorders as well. So coming to the end of my talk, this is all I really have to tell you all, is what I do in my outpatient services. And if this does not happen, only then the child goes for a formal development assessment like a Bailey scale or a Denver development screening, depending on the time available to the child. By 2 months, you should get social smile. An early measure of head circumference objectively tells whether this child was premature or asphyxiated, is having a problem. By 4 months, there should be good head control. Head should not fall forwards or sidewards. The child should try to roll over. If he can't do an ATNR and Moro, they should have gone away. It is the age of catching, 4 months. He should be able to catch with eyes, catch with ears, and catch an object placed in the hand. By 6 months, the child has half word, what's called babbling, and he plays and reaches and grasps the toy actually. 8 months, stranger anxiety and sitting without support. Reciprocal play starts by 9 to 10 months. The child can say tata mama with meaning and has something called joint attention. You show a light and you talk to the child and say that is light. Both of you are looking at the light and learning together. If it is not there, thinking autism spectrum disorders. Hand-eye control by pincer grasp. And by 12 months, the child should say one word and respond to name call and should be able to stand. Now, the most important thing is that I do a development assessment. How do I make sure I don't miss these things? So if there's a child who has high risk factors like an asphyxia, prematurity, hypoglycemia, or parental concern that there is developmental delay, just issue an ordinary notebook so that when they come back to next time, this child is flagged. You think that, okay, I gave a notebook because this baby has a problem. And then I simply write, can the child play well? Can he sleep well? Can he feed well? That is the first 3 words. That's what matters at the end of the day, not a score on a Bailey scale. And then I do the age appropriate milestones. And this will make sure that most children who we see in the outpatient get attention at the right time and get to grow and develop to the full potential and be good, healthy children later. Thank you, IAP Tamil Nadu, for the opportunity to speak to you all.
Jagdish, you are muted. Jagdish, you are muted.
Yes, sir.
Yeah.
Thank you, sir. Thank you, Naveen Jain, sir, for the excellent presentation in a more simple way and in a clear-cut way of identifying high-risk symptoms. Actually, the visuals are very good, sir. So very so informative and very clean. Next, we move on to the another speaker.
Sir,
The next speaker.
Jagdish, just one word. So I just
Yes.
wanted to tell. So I'm hearing Dr. Naveen Jain for the past 20 years. So
Yes.
multiple lectures I have heard. I have even gone through your book, which you issue for this the blue book, sir, the blue book, right? So every time I hear from you, I learn, I brush my memory on things, even though I practice child development. Thank you for your bullet points. All are bullet points, nothing vague or something like. Thank you for being here with the IAP TNSC and accepting my invite to be here, sir. Thank you very much. Over to Dr. Jagdish. Yeah.
Yes, sir. So we move to the next speaker, Dr. Vivekanandan. He is going to speak about the sleep disorders, sleep problems in preschool children, and clinical approach and red flags. Dr. Vivekanandan, sir, he finished his MD Pediatrics, then a fellowship in pediatric pulmonology and sleep, and postdoctoral fellowship in pediatric pulmonology at ICH, and European diploma in pediatric respiratory medicine, and Indian diploma in pediatric critical care medicine. So now a consultant pediatric pulmonologist and bronchoscopist and a sleep specialist. So now he's consultant at Kanchi Kamakoti Child Trust Hospital and VVV Pediatric Respiratory and Sleep Clinic. His special interest in pediatric bronchoscopy and pediatric interventional pulmonology and pediatric sleep. Over to you, Dr. Vivekanand, sir.
Thank you, sir, for the kind introduction. I would like to thank IAP TNSC for giving me this opportunity. Is my slides visible, sir?
Yes.
Yeah,
Yes.
it's visible. Yeah, you can move.
So over the next 15 minutes, I'll be briefly discussing about preschool sleep problems, which is the fulcrum of pediatric sleep, actually. And I'll give a brief clinical approach and red flags from a general pediatric point of view. So my scheme of presentation will be, I'll give a brief introduction of preschool problems in sleep, office screening, basic what we can do. What are the common problems? I will go through some interesting cases which I've seen over the last couple of years and with a basic approach to them, and I will conclude with some red flags. Now, what is normal sleep for a preschooler? So they essentially all preschool children need total sleep of around 10 to 13 hours per day, with night sleep between 9 to 11 hours. Day naps, one nap is acceptable till 4 to 5 years of age, which should not last beyond 3:30 p.m. and it should be ideally for an hour or 1.5. Sleep latency, that is from the time the lights is off to the time the child is in sleep, should be less than 30 minutes and should not be more than an hour. And brief and self-settling night awakenings are acceptable. Always it is prudent to exclude a medical cause. From a pulmonologist point of view, I will always look at an allergic rhinitis, asthma, GERD, atopic dermatitis, chronic cough, or neurodevelopmental disorder. So it is always worthwhile screening for a medical cause as well. Now, this is basic. I think Nelson always mentions BARS sleep screen, which is mandatory and which is from a gender pediatric point very helpful. So we seek for bedtime issues, whether there is any resistance for the child to sleep, is there any delay in onset, any fears, any special needs the child has. And with regards to the next thing is E is for excessive daytime sleepiness. We might have difficulty in waking up or excessive sleepiness in the daytime with inattention and hyperactivity. Awakenings in the night, which may be due to parasomnias, night terrors, call outs or special needs children. Regularity and duration of sleep. This is the most important aspect of this topic. Snoring, frequency pauses, and dry mouth or headaches in the morning after getting up. Now, this is the first scenario. This is a 4-year-old girl who was parents actually Googled and sought help. They were surprised that there exists a doctor for a pediatric sleep issues. So the child had difficulty in waking up in the morning. She sleeps between 12 to 6. Dinner 7:30 p.m. Plays extensively till 10:30. Uses gadgets till 11:30 while in bed from 10:30. Naps between 4 to 6 in the evening as a child is tired after school with normal growth and development. Now, this is a clear-cut diagnosis of insufficient sleep with a very poor sleep hygiene. We just taught basics, we retrained the sleep program and reassured and follow up the child. Now, what is sleep hygiene? The 10 take-home points will be every child, particularly in this age group, sleep and wake at the same time every day. Avoid electronic gadgets, high stimulating activities closer to bedtime, that is 1 hour before. Bedroom environment should be calm and quiet. Use the bed only for sleeping. Keep nightlight dim, 0 watt. Blue light is ideal recommendations. Increase sunlight exposure in the morning. Keep a regular daily schedule and consistent bedtime routine. An afternoon nap is not required beyond 4 years of age, and in case of napping should not exceed beyond 3:30 p.m. Avoid sleeping in an environment other than bedroom and encourage physical activity as much as possible in the evening time between 5 to 6 p.m. So this is we sometimes put up these charts for children to put up in their room so that it's like a game for them. So this is the first scenario where it is just a case of poor sleep hygiene. This is the normal sleep recommendations by age wise, which is given by the National Sleep Foundation by the American Society. So with regards to preschool age, which is the age ideally between 2 to 5 years, it is between 10 to 13 hours, including naps. Now, moving on to the second scenario. So this is a mnemonic or a simple phrase which my teacher used to tell me: what is needed to fall asleep is needed to return to sleep. So that means this is a young IT couple who brought their 2-year-old child for sleep issues. The child is unable to fall asleep by himself, sleeps well besides parents, frequent awakenings in the night, disturbing the parent as well as the child. Cries a lot when placed in the crib. Child is always rocked to sleep from the beginning by the grandparents and subsequently by the parents. Child moves a lot during sleep. Parents are awake throughout normal growth and development. There is no snoring. So this is an extreme scenario where this is from a famous video from Children's Hospital of Philadelphia. So this is called sleep onset association. So this child who was an infant has actually been trained to sleep by putting water on his legs. So this is the child which is doing the same thing because child cannot fall asleep by himself unless water is poured onto his limbs. So this is as extreme as he can get. So what is the problem with this child whom we are discussing? The child was having a problem of rocking. So this is called BIC, also called as behavioral insomnia of childhood. It affects as much as 30% of children. And if left untreated, it persists into adulthood. Insomnia can be descriptive to the parents as well as to the child and can be a significant cause of caregiver insomnia as well. Now, what is the sleep onset association is the type which what we saw. The sleep onset child has been primed to sleep by either a rocking movement or child can be even taken outside for a drive or anything. Breastfeeding beyond 7th month or 6th month of age to put the child to sleep is also another form of an association. So limit setting is we have not instilled the appropriate sleep hygiene in the child. Therefore, the child's what the child does is child resists and postpones sleep time, and sometimes we can have a mixture of both. So this is how we treat this. We just follow a behavioral approach, no drug policy here. We taught appropriate associations, put the child to bed awake and drowsy but not when asleep. We did the same 3 months later, peaceful sleep for both parents as well as the child was there. Sometimes we follow extinction therapy, bedtime fading, and positive reinforcement techniques. By sometimes we also involve a sleep psychologist if available in our sitting. This is the audio of a 5-year-old girl. A frequent awakening in the night, sleeps at 10 p.m. Agitated, cry, screaming, inconsolable, frightening the entire family, including the grandparents. Child has a lot of autonomic issues, sweats a lot during the event, at times walk during sleep with eyes closed, does not remember the events the next day, happens once a week. So this is essentially from time immemorial called pavor nocturnus, and what we are all used to know is what is called as night terror or sleep terror. So these are all non-REM parasomnias which occurs in the first half of the night. These are called confusional arousals. They can have just whimpering movements, some speech movements, or some brief arousals, and they fall back to sleep. They can have sleepwalking, sleep talking, also called somnoloquio or somnolambism, and sleep related eating, which is very rare. And what we saw here was a classical example of a sleep terror. REM related parasomnias are more of an adult phenotype. We usually don't see except for nightmare, which is very common in the second half of the night. Other rare associations are sleep enuresis and sleep related hallucinations, which are usually rare. So we give time, educate, identification of triggers, avoid sleep deprivation, therapy and relaxation, and programmed awakening. And we rarely resort to benzodiazepines when it's a very routine affair which occurs on an everyday basis. So parasomnias are self-limiting, exacerbated by a sleep deprivation or another disorder, and sleep extension or hygiene and safety measures to avoid injury should be taken care. Resolved by adulthood, but they can persist or coexist. If another sleep disorder is suspected, we warrant for a video polysomnography. If the movements are stereotypical with repetitive brief episodes, then we refer to a neurology for a video EEG to rule out a seizure. Moving on to the last two scenarios. This is a common bread and butter of any sleep physician. This is a 3-year-old boy referred by a general physician. No guesses for what is the problem here. This child has a persistent snoring for the past 6 months. Choking has been observed at times in the night. Child has mild increase in BMI, regular snoring, and grade 3 tonsillar hypertrophy. So what is the diagnostic criteria? This is a clear-cut case of an obstructive sleep apnea. So do we need objective evidence? Yes, in the current scenario, when you have snoring, labored breathing, or sleepiness, or hyperactivity, or behavioral abnormality in the morning, plus polysomnographic evidence of an AHI index more than 1, or abnormal hypoventilation in the night, then we entertain a problem of obstructive sleep apnea. Mild OSA is an AHI less than 5, that is 1 to 5. Moderate is between 5 to 10, and severe OSA is when the number of events are more than 10 per hour. So we did a polysomnography for this child. This child had a severe OSA. We referred to ENT for adenotonsillectomy, and we reassessed the child after 12 weeks along with weight loss measures. Child is doing very well. Now, when do we treat OSA is when the AHI index is more than 5, treatment will be beneficial, and adenotonsillectomy continues to be the primary first line of treatment. So mild OSA, we can give intranasal steroids or Montelukast for a brief course, not for a prolonged period. But in case of a moderate to severe OSA, we resort to adenotonsillectomy provided there is significant adenotonsillar hypertrophy. Now, moving on to the last scenario. This is a 5-year-old girl who was brought to the clinic with history of grinding of teeth during sleep for the past 3 months. She was developmentally normal. She is present for the last 6 months actually. There is recent change in school and school absenteeism. There is no history of snoring or any other sleep issues was not present. Normal dental hygiene, has early morning headache and feels fatigued at times during the day. So this is currently termed as sleep-related movement disorder or previously abbreviated bruxism. Why do kids grind their teeth? It can be any of these. It could be even second-hand smoke. It could be dental issues. It could be an anxiety. It could be any subconscious stress and sleep or mental health disorders. Now, what is the diagnostic criteria of sleep-related bruxism? If there is presence of regular frequent tooth grinding during sleep and the presence of one or more of the following signs, then you entertain a diagnosis of sleep-related movement disorder. So if there is consistent tooth grinding with an abnormal tooth wear, consistent with above reports of tooth grinding, or when the child wakes up in the morning, there is a transient jaw muscle pain or temporal headache or jaw locking movement upon awakening, then we entertain a diagnosis of sleep-related movement disorder. We usually don't do a polysomnography in this scenario. So there is no role for sleep tests. We have to differentiate whether it's a primary dental problem or it's a secondary problem. We always exclude seizures in a developmentally abnormal child, and we exclude dental issues. Now, how we manage this child is eliminate stressors. There was a recent change in schools, so school absenteeism was there. We refer to a child psychologist. Sometimes we encourage supine lying with neck support. Local heat for jaw paining acts more of a placebo therapy. Dental referral, if any. There is no role for any drugs here. SSRIs can actually worsen the symptoms. So I feel psychologist input has helped us on innumerable occasions in this scenario. So if there is no consequences, just follow up. If there is abnormal tooth wear, refer to a dentist. If there is orofacial pain with temporomandibular joint issues, you follow hypnotherapy, cognitive behavioral therapy, and look for always OSA, anxiety, gastroesophageal reflux, or any other sleep coexisting disorder. So it's a multidisciplinary management. Moving on to my last slide is, so when should you consider referral and or a reflex? When you have regular night snoring for more than 3 nights a week for more than 4 weeks, that's the first red flag to referral to a sleep specialist. There is suspicion of a obstructive sleep apnea, and this should be present in the absence of a URTI. When there is pauses in breathing, that warrants a referral. When there is excessive daytime sleepiness and morning headache after getting up without vomiting, then it prompts a referral. When there is repeated unusual movements, which is very frequent during sleep, that is warrants a referral. When there is constant tossing and turning with repeated leg kicking, it is a red flag. When the child takes more than an hour to fall asleep, it could be behavioral insomnia of childhood. This is a very important red flag as it can persist till adulthood. When there is frequent awakening in the night, which is not self-limiting, this is also warrants referral. So always remember to screen the bare screen as mentioned by Nelson from time immemorial in our textbooks. And I would be happy to answer any questions and hope I have not put anyone to sleep during my talk.
Thank you.
Thank you, sir.
Okay.
Dr. Vivek, very nice presentation. So one query from my side. So
Yes,
we
sir.
deal with developmentally delayed children, right? So many of them have erratic sleep patterns, and they have most of the parents have this issue with the late sleepiness, erratic sleep, disturbed sleep. Onset will also be delayed. Maintaining the sleep will also be delayed. So such children, knows they don't have they will not be able to take up the good therapy sessions next day.
Yes, sir.
So how will you what advice will you give the developmental pediatricians here? So
Yes, yes, sir. This is the most common scenario and the scenario when we all have very extreme difficulty. So what we usually do is it is usually a problem of insomnia which you encounter in this child, sir, because of lot of sensory processing and integration issues. So we teach them the basics, and majority of the time we have give them a course of melatonin to promote their onset within an hour, which helps in maintaining their sleep because they're also going for therapy the next day. So behavioral strategies, sometimes cognitive behavioral therapy along with melatonin, and we have resorted to using melatonin for a prolonged periods of time, sometimes even for years in this scenario, which is reasonably safe from long-term safety data. So behavioral approach, routine hygiene, along with drug therapy with melatonin, and the common problems which we see is behavioral insomnia.
So, good evening, sir. Dr. Balaji from Dharmaburi.
Yes, Balaji.
Actually, yes, sometimes the parents will come and complain that even after good sleep at night, the children schools, even it happens up to 5th standard or beyond 5th standard. Sometimes even adolescent also, some parents will complain like that, sir. Even
Okay.
after the good sleep at night, the teachers complain that your kids are sleeping during your school times. So
Yes, sir.
specifically, we have to work up for these complaints, sir. Actually.
Sir, very important, sir. Particularly when a child has slept well in the night and child has excessively sleeping in the daytime without snoring, in an adolescent age group particularly, then what we usually think is we ask for symptoms of narcolepsy actually, sir. Does a child fall asleep in unusual places? That is when talking to a friend or moving in an escalator or in a lift or while traveling by bus or auto. So if a child sleeps well, has no snoring and has excessive daytime sleepiness with an unusual sleep pattern in the daytime, then it is always worthwhile referring. The topmost is considering it will be the diagnosis will be a excessive daytime sleepiness. Probably we have to rule out a narcolepsy in this child, but we usually see it in a pre-adolescent or adolescent populations.
Can I have one doubt,
Yeah.
Dr. Somasundram?
Yes, sir. Yes.
Lovely talk. The only thing is, in this topic is in the preschool, we should always screen for iron deficiency, anemia, and worm infestation, and rarely the scabies. These are all the three medical issues we always come to our mind also. Other, that's a lovely talk by Dr. Vivek. Thank you.
Thank you, sir. Actually, a very important point, because many of these kids also have a restless leg syndrome, which are not included where they have iron deficiency coexisting.
So another question from Dr. Ramesh sir. What are the behavior problems or mannerisms before going to sleep? What are the behavior problems or mannerisms before going to sleep?
Sir, I'm not exactly, I couldn't understand the question.
Yeah, from Dr. Ramesh.
Ramesh, sir, if you
Ramesh
are
sir.
here, you can directly ask the speaker. I think Dr. Ramesh from Annamalai. Yes, Ramesh.
So what I'm asking is,
Yes, sir.
some children before going to, especially the preschoolers, do
Yes,
some
sir.
funny things like catching the mother's hair or the ear lobule, or
Yes,
sometimes
sir.
even the umbilicus of the mother.
Yes,
They
sir.
have some funny behavior, no?
Yes, sir.
How long it lasts? Is there any special treatment for that?
Sir, a very important valid point, sir, because this falls under the spectrum of sleep onset association, sir. The child associates falling asleep with these mannerisms. So it is a sleep issue, sir. It is called the second scenario, behavioral insomnia of childhood. So we definitely retrain, we gradually extend this behavior and reinforce normal sleep hygiene practices.
Some
So we
children do some self-gratification movements, like
Yes, sir.
bumping on the bed or
Yes, sir.
stroking the genitals, lying in the prone position.
Yes, sir.
What is the significance?
Sir,
Is it,
if it happens in a development, usually we can see this in a developmentally challenged child, sir. But if it happens in a developmentally normal child, it would also fall into the purview of an association, sir. Child has some gratification to fall asleep. That current guidelines and recommendations say that breastfeeding beyond 6 months to initiate sleep for an infant beyond 6 months is also a form of an association, it seems. So these are all negative associations, sir. We encourage positive associations like music therapy or gentle patting is acceptable, or a lullaby. All these things are positive associations. Western world usually encourages pacifiers, which is still socially not much relevant in our populations.
I have heard a few mothers complaining of masturbation-like activities in preschoolers before going to sleep. Have you come across such problems?
Not very commonly in a behaviorally developmentally normal child, sir. But probably it is a problem of obviously a self-gratification problem.
Sir,
Thank you,
like
sir. Thank you.
toilet training, is there any message for a sleep training, especially under 2 years, sir?
Sir, definitely, sir. A very important and most relevant question for today. What we usually encourage is, as soon as the child is born, sir, what we want to convey to the general pediatrician when they come for the first vaccination, second and third. I think a question on the sleep pattern behavior should be going on along with the developmental, sir, because both go hand in hand. So we ask for development. I think simultaneously it will be worthwhile, prudent to ask for a sleep related issues, and we can tell what sleep pattern is normal and what is abnormal, so that we catch them early.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you.
So regarding summarizing today's events, today's topics, it reminds us that the pediatrics is not merely about treating illness, but not about nurturing human potential from the earliest stages of life. The discussions on high-risk infant follow-up and sleep problems in children highlights how early identification and timely intervention can shape the future of the child and ultimately society itself. So at this moment, I am reminded of a timeless wisdom from Tiruvallur in Tirukkural. யாழினிது குழலினிது என்பத மக்கள் மழலை சொல் கேளாதவர். This beautiful choral tells us that the sweetness of the lute and the flute can be appreciated only by those who haven't heard the delightful speech of the child. So on today's topic regarding the Naveen Jain's topic is clearly mentioned about at any age we should ask history regarding the feeding, playing and sleeping. These are the three important things we should ask the mother: feeding, playing and sleeping. Then he clearly mentioned about the milestones at 2 months regarding the social smile. We should not wait even for the 2 weeks, and then head control at 4 months, and indication is an indication for early signs of cerebral palsy, and 4 months complete head control and rollover, absence of ATNR reflex and motor reflex, and this also the catching month is 4 month, and then importance of doing BERA and hearing impairment, and child is hearing impaired is identified, you should start on hearing aid by 4 to 8 months. Then at 8 months, the child should straight and with the legs open, and importance of princess grasp at 9 months. And then by 9 months, the reflection should be tested for children. So before 1 year, the hearing and vision should be corrected for the child. And at 12 months, the child should stand. When the child stands on the toe, it's always abnormal. So, and he also states about the importance of giving a notebook to a child who has some problems. So in review, we can clearly identify the problem child. In DAC, for the past 8 years, we are so following the same things, sir. We are issuing the notebook, high-risk notebooks to every individual. I think this all these things are already we have in the book of Nurturing Care, NCECT workshop books. Is clearly it tells us all the things suggested by you, sir. Thank you once again, Naveen Jain, sir, for again insisting about the basic things of early integration of high-risk symptoms in the high-risk newborn. Thank you, sir. And regarding in the Vivekananda's topic, he clearly mentioned about the sleep problems and how to treat them also. So he clearly mentioned about the sleep pattern and hours of duration of each age according to the age, and then the insomnias, and then sleep-related movement disorders, sleep bruxism, and red flag signs in the sleep. Both the topics are very interesting. So as a clinicians working in the busy outpatient settings, we can often pressed for the time. So where developmental observation, behavior understanding, but must become an integral part of the routine pediatric care. So not an optional addition. So I sincerely appreciate today's esteemed speakers for bringing practical and real-life clinical perspectives that will help all of us translate knowledge into everyday practice. And congratulate the organizers for conducting such meaningful academic programs that strengthen our collective commitment towards child development and holistic pediatric care. Thank you. Thank you once again, Dr. Somasaram, for giving the opportunity today. Thank you.
Thank you, sir. Thank you, sir. We now move into a second session of the day panel discussion. It is my privilege to introduce the moderator for this session, Dr. Somasundaram, sir, a president of IAP TNSC and a senior developmental pediatrician, DSOL Adyar, Chennai. Sir is a president IAP Tamil Nadu Chapter 2026, president IAP Chennai 2025, joint secretary of IAP Chapter of Neurodevelopmental Pediatrics 2024 to 25, central IAP EB member of EB member 2020 to 2022, Secretary IAP Tamil Nadu 2017 to 18, and Secretary IAP Chennai 2014 to 15. Over to you, sir.
Thank you, Dr. Madhubala. So after those two enlightening talks on various two different topics. That's the high-risk infant follow-up and the sleep problems, which are much needed by every practicing pediatrician. We will move on to the panel discussion, which is on behavioral problems in the preschool and the school age children. So this will be the problems which a pediatrician will also face, and as parents and our relatives also face on a day-to-day basis. So this will be an essential thing. Even though we know certain things, we will not be able to advise them accordingly if we doesn't know the in-depth of these issues. So over the next 40-45 minutes, we will be dealing on certain case scenarios related to behavioral and in preschool and school age children. Is my slides visible?
Yes, yes,
Yes, sir.
yes.
Yeah. So the next 45 minutes, we will look into certain case scenarios on behavioral problems in preschool and school children. Before I introduce my panelists, so just to setting the context, so what is behavior? Behavior is something which we show physically and emotionally that humans engage in and are influenced by their culture, by attitude, their value, their ethics, their authority, their rapport, and persuasion and or genetics. So why children behave inappropriately? Because they believe their inappropriate behavior is working for them, because sometimes they do the inappropriate behavior to avoid or escape a situation or a person. For example, if some stranger anxiety, that is an abnormal behavior which they wanted to avoid going to a different person. To obtain an object or an attention, temper tantrums is an example. To change the level of stimulation which they are attaining. So these are the various situations why the child behave inappropriately. So what are the inappropriate challenging behaviors? So why these challenging behaviors are not good for these children? So they interfere with the children's learning, development, and success at play. If they are not having a good behavior, is harmful to the child himself, harmful to the other children, and harmful to the adults also. Puts the child at high risk for later social problems, because the child cannot socially interact and have school failure if their behavior is not good. So usually these are all the behavioral disorders. Just unmute someone, please. So all those behaviors fall under these four categories. That is either an emotional deprivation, it's because of some emotional deprivation, or some physical deprivation, or a social deprivation. So what are the conditions which can come under emotional deprivation? If the child is not being shown some emotional attached, then the child shows temper tantrums, breath holding spells, jealousy, insomnia, nightmare, somnolence, bruxism, all are because of emotional deprivation. What are due to physical deprivation? Behavioral disorders coming under these categories are encopresis, tics, nail biting, pica, thumb sucking, all these come under physical deprivation. Social deprivation, social phobia, stealing, lying, aggressiveness, sibling rivalry, juvenile delinquency, all come under social deprivation. So to discuss the scenarios, we have four esteemed panelists. All are developmental pediatricians in this field. For Dr. Nimi Joseph, she is the consultant in developmental pediatrics and National Institute of Physical Medicine and Rehabilitation from Preschool, and currently she is the treasurer of the National Neurodevelopment Pediatrics chapter and the co-editor of Developmental Pediatrics Today. Welcome, Dr. Nimi Joseph. And Dr. T. Kanivoli, she is currently the professor at Sri Manakula Vinayakar Medical College, Puducherry, the EB member of the IAP TNSC Growth and Development Pediatric Chapter 2025, and South Zone IAP 2026 is the EB member of South Zone IAP, and the director of the CDC at Manakula Vinayakar. Dr. Madhubala Selvam, she is the consultant developmental behavioral pediatrician at Mira Foundation for Child Development and Child Development Salem, and currently the secretary of the IAP TNSC Growth and Developmental Pediatrics chapter. And the last The panelist is Dr. Rini Jose Benson, the consultant developmental pediatrician at Vistara Child Development Center and visiting consultant at Mehta's Hospital. So these four colorful ladies will give us the brief scenarios for the 8 case scenarios. So we'll start with Dr. Nimmi Joseph. So this is the first case scenario where everybody is well known this thumb sucking, and it's an hard-earned thing, and we have heard that even 4-year-old child having the thumb sucking along with the same handkerchief, he use it till 5 years. Without that handkerchief and the thumb, he will not be able to go to sleep. So Dr. Nimmi, this is a 3-year-old child with persistent thumb sucking since infancy. The child's development is normal. The parents are anxious about the dental effects. How should we approach? When to reassure, when to intervene, and when to refer?
Good evening, everyone. Thank you so much, Sundaram sir, for this opportunity, and I thank IAP Tamil Nadu and all the senior members and attendees for this opportunity. I hope I am audible.
Yeah, you are audible. Yeah, you can talk. I can move the screen.
Okay. So, thumb sucking is basically a normal soothing behavior originating from the sucking reflex, and it is even seen in utero. So, as pediatricians, we have to differentiate whether this is physiological self-regulation behavior or a persistent habit disorder. I'm not able to see the screen. I'm sorry.
So change the screen.
One second. Shared content. Yeah. Yes. Sorry. So till what age is thumb sucking okay? From birth to 2 years, it's completely normal. It's a part of sensory regulation and is associated with sleep initiation and comfort, and no intervention is basically required. From 2 to 4 years, it's still common and often reduces naturally when the child starts school. And monitor the frequency and intensity, and gentle behavior shaping interventions can be begun. And after 4 to 5 years, considered as a persistent habit. And there is a risk of dental malocclusion, anterior open bite, and speech and articulation issues, and social embarrassment. After 6 years, active intervention is required. Assess for anxiety disorders, emotional stress, or neurodevelopmental disorders or attachment difficulties, and sleep issues. So coming to the interventions, 2 to 4 years, habit shaping stage. So the goal is to increase the awareness. Ignore during sleep, but gentle reminder cues during daytime, like hands down, and reward the dry thumb days. And provide sensory alternatives like a soft toy or fidget toy or chewy tubes if sensory seeking is present. But avoid bitter solutions, which has been practiced usually, and then punishments and taking the child to a dentist and threatening the child. All these things should be avoided at this age. 4 to 6 years, it's a motivation phase. Here we will go step by step. So step 1, we will assess for all the triggers. Is what is precipitating this thumb sucking? Is it boredom, sleep, or anxiety, or excessive screen time? Nowadays we see a lot of children with excessive screen time, and they will be sucking their thumb and watching the screen. Then is it a separation, stress? Then keep a behavior chart, a star chart, and small rewards. Whenever we ask this, parents will not be compliant with this. So we have to make sure that, we have told them enough for them to continue this behavior chart for such a long time to get results. 1 week and 2 weeks is not going to work. They should at least do it for at least 2 months persistently to get results. And step 3 is always habit reversal training. It's an awareness training where the child is prompted to, whenever they feel like sucking the thumb, they are advised to do a different activity, like hold a toy or keep their palm on their thighs, or hold their palms together and things like that, whatever is acceptable. Step 4 is night management, where we can use thumb guard or socks at night, but then only if the child agrees for it. It should not be forceful. And 6+ years, a structured intervention is required. So always assess for all the anxiety, ADHD, neurodevelopmental disorders, emotional trauma and school stress. Intervention is habit reversal therapy which is the gold standard, which I've already mentioned. Then cognitive behavioral therapy, dental referral if a malocclusion, and occupational therapy, sensory issues are there, and family counseling. Coming to the dental issues, prolonged thumb sucking may lead to misaligned bite, overbite, then backbite, palatal roof changes, chewing and swallowing difficulties, speech problems, and irregular tooth wear. So I've shown few pictures of that too. And coming to the mechanical therapy or reminder therapy, where you can see the pictures of in an extraoral approach, we can use the thumb guard. Then there's a splint which can be used. Then that thumb covers and hand covers, which are all available online. In oral approach, optimum time for appliance, we can use oral appliances which will be done by dentist, and appropriate age is 3 to 4.5 years. I have put up some pictures of the oral appliances little later. Coming to the when to refer. I mean, we will be, as general pediatricians, we will be advising all these. And even if we are not able to get rid of this habit, refer to a pediatric dentist if dental problems, as I've mentioned, is present, or when the habit is still present when the permanent incisors are erupting. And also when nowadays parents come with requests of putting some appliances because they are not able to control the habit. And refer to a developmental mental health specialist if habit persists beyond 6 years of despite intervention, a child reports inability to control the urge, or associated separation, stress, emotional dysregulation, or coexisting ASD, ADHD, and learning difficulties. As you know, ASD is a disorder with a lot of sensory issues and sensory seeking. So this is very commonly seen. This mouthing and thumb sucking is very commonly seen in these children. So they might need developmental pediatrician referral and occupational therapy and other interventions to get rid of this habit. And multiple habit disorders, if multiple habit disorders are present, that also should be referred to a proper mental health specialist or a developmental pediatrician. These are few appliances. I forgot to put the most commonly used one is a habit breaking appliance, which is also a fixed appliance, which I haven't put it here. That is used for both the tongue thrust and for thumb sucking. And this is bluegrass appliance, quad helix. We don't have to know the details, but this has been advised and is found to be very effective in preventing thumb sucking in children more than 6 years with persistent thumb sucking.
Perfect. So you have compartmentalized them into 3 categories. 2 to 4 is the one where the habit shaping has to begin. If not, by 4 years, they will have permanent issues of the dentition, have the articulation issues can also start if by between 4 to 6 years you are not doing something. And beyond 6 years, it's the right time to refer to the developmental pediatrician to look for any other issues of a developmental problem like anxiety, ADHD, or something like. So what the tagline will be, this is a reflex. Thumping sucking is a reflex which can become a red flag later. So from reflex to reflex to risk, know when reassurance should end and intervention should begin. You cannot say that no, do something, pull the hand outside, put some this neem oil, or go for that femina ointment or something like, even if the child is going on beyond 5 to 6 years, 6 months. So 5 to 6 years, sorry. So going on to the next case scenario. So this is also a common case scenario, which even you must have experienced in your OPD. When you give an injection by about 18 months of age, the child goes like this, cries, and then goes like this. So it will be panicky and frightening for the parents. And the child comes back to normal. I mean, the parents and the doctor also show some signs of relief, because the parents will be frightened. Your vaccination has done something to the child. So, Dr. Kanimuli.
Yes, sir.
Now it's so Dr. Kanimuli, so this is a 2-year-old child presents with recurrent episodes of crying followed by breath holding cyanosis and brief loss of consciousness. Parents are terrified. How should we evaluate? You know that there are two types, and what should be the differential diagnosis and red flags for this condition?
Thank you, sir. Thank you all seniors, colleagues, and my dear friends. So this, whatever sir has explained, is a classical presentation of cyanotic type of breath holding spell. So breath holding spell is seen commonly in toddlers between 6 months to 5 years of age, where the incidence is around 4 to 5%. Most of them may have a positive family history also, because it is inherited by an autosomal dominant with reduced penetrance. There is no test for diagnosis of breath holding spells as such. It is mainly clinical, where you have a typical sequence of events in history, and there should be a normal general and central nervous system examination. So we have two types of spells. So the scenario was a cyanotic breath holding spells, which is the most common, seen in 62% of children. So there will be some inciting event which makes the child angry, frustrated. They start to cry vigorously, and they stop crying by holding the breath, after which the child becomes cyanotic. There is loss of consciousness with or without seizures. So the consciousness usually recovers within 60 seconds, which is very important to note. And after that, they might be sleepy for some time. So whether it is a cyanotic or a palate spell depends on whether it is a sympathetic overactivity or a parasympathetic overactivity. In sympathetic overactivity, there will be inhibition of breathing. They become cyanotic and it becomes a cyanotic spell. If there is a parasympathetic overactivity, there is increase in vagal tone leading to bradycardia. There is a transient asystole and then they become pale. So in palate spell, usually the trigger is a pain or a sudden fright, after which there'll be cry, which is not as vigorous as you see in a cyanotic spell. And then they become pale, limpy with loss of sensorium, which again recovers within 1 minute. And we should see there is no clear postictal confusion. They might be tired, but there's no postictal confusion, which differentiates this condition from a seizure. So evaluation, most of the time, if the child is pale, we'll do a CBC with the serum ferritin. If it is a palate spell, then we might have to do an ECG to rule out arrhythmias, especially congenital long QT syndrome. And EEG, if we are going to have atypical features, like if it is within outside the typical age group, there is no clear trigger for the onset of episode. It is lasting for more than 1 minute. There is postictal state. And if it is occurring even during sleep, all these can point towards the presence of a seizure, during which we'll have to do EEG as well. Otherwise, just CBC and serum ferritin for the current scenario will be enough. And management, the mainstay of management is family education. We first have to reassure them that it is a benign, it is a reflex involuntary event. It is not an attention-seeking behavior like a tantrum or some other behavioral conditions. And there is no neurological sequelae, although the child can even have seizures, and it is totally going to disappear by 6 years of age. So we can try to prevent the episode by avoiding the triggers and also distracting the child during such triggers. But if the incident happens, then they need not panic, keep calm, put the child in the safe position. It recovers within 60 seconds, but if it doesn't recover, then we might have to seek a medical attention. Iron supplementation we can give if there is anemia, but studies have shown that it can be given even in children without anemia for a short duration of 3 months, and it might be a little helpful in preventing the recurrent episodes. And as regarding the medications, it is little controversial, but if there is recurrent and very severe episodes, intense episodes, then studies have shown that atropine can be used in palate spells if the asystole is prolonged. And in cyanotic spells, studies have shown efficacy with the use of piracetam and levetiracetam. And prognosis is very excellent, and there is no neurological sequelae in such conditions. So differential diagnosis, so as already discussed, seizure is a very close differential diagnosis, and it is recurrent. So we are going to consider epilepsy also if there is an atypical episode lasting more than 1 minute and a postictal state. And arrhythmias, we are going to consider if it is going to be a palate smell, do an ECG and rule out the arrhythmias. And other seizure mimics like shuddering and hyperexplexia. Shuddering is like shivering episodes involving the head and the upper limb. It is usually seen in children between 6 months to 4 years of age. They can have brief episodes of apnea or loss of consciousness following the episode, but here there'll be multiple episodes and a typical history can differentiate both. And hyperexplexia, it is an exaggerated startle response. There'll be some noise or something to startle the child, followed by stiffening, and there can again be brief episode of cyanosis or a loss of consciousness. And this can be seen even in a neonatal period. And laryngeal stridor and whooping cough can again have cyanosis, but you'll have the other associated symptoms which are going to differentiate from the breath holding spells. So red flag signs, as I already told, all the atypical features which is not coming under the classical sequence of events should always raise suspicion for alternative diagnosis. Like onset less than 6 months, we might have to even consider the cyanotic heart disease in such children. There is no clear emotional trigger occurring even during sleep, and cyanosis occurring after the loss of consciousness and prolonged episodes lasting for more than 1 minute. There is a clear post-ictal state or a confusion. And as I already told, there should be a normal general physical and CNS examination for breath holding spell. If it is occurring in a child with developmental delay, then please rule out your alternative differentials.
Perfect. Dr. Kanimali was very clear. So usually it starts from 6 months of age, goes on till 3 years of age, and the duration should not go beyond 1 minute, and it should not occur during a sleep. So if these things are there, then we have to look into for other conditions. So the tagline will be, it's a very common condition, frightening, but rarely dangerous. Prognosis is excellent. Diagnosis is always clinical. The confidence is therapeutic rather than medicines for the parent. So we will move on to the third case scenario. So we should have experienced even kids and our children showing tantrums like this. So why they are showing tantrums? To achieve something, to avoid something. So they will be doing like this. So, Dr. Madhubala, so this you have a 2.5-year-old child, daily temper tantrums, screaming, hitting, throwing objects when demands are not met. Parents are exhausted and worried. Is this normal or a behavioral disorder? Does parenting style have a role? What red flags? What is the effective strategy to control such things? Over to Dr. Madhu.
Thank you, sir. So, temper tantrums is a behavioral disorder. Yes, here the parenting style have a role. So, the main parenting styles are the authoritative, authoritarian, permissive, or neglectful parenting styles. So, authoritative is where the parents provide support, structure to the child, and also they'll give the rules to the child with providing independence. Whereas authoritarian parents are strict. They have strict control and strict rules will be provided to the child, whereas permissive associated with higher frequency of tantrums due to lack of structure, inconsistent or passive responses. So here authoritative parents combines warmth with clear boundaries, teaching the children to manage emotions and reducing the power struggles. So it is very easy for the authoritative parents to maintain the temper tantrums in a child. So the red flags.
Yeah, sorry.
Yes.
Yeah.
So here the temper tantrums usually occurs between 12 months to 4 years of age, and the behavioral pattern during the tantrum will be crying, flailing arms or legs, falling on the floor, pushing, pulling or biting or hitting, and the duration is usually up to 15 minutes, lasting for less than 5 times a day, and the child should return to normal between the tantrums. So the red flags here are if it is continuing beyond 4 years of age, if the child injures themselves or others during the tantrum, lasting longer than 15 minutes, and also for more than 5 times a day, and the child has persistent negative mood between the tantrums. So these are the red flags that has to be kept in mind. And the most effective strategy to control the temper tantrum is proactive prevention. So proactive prevention is nothing but anticipating the triggers, managing the environment, and acknowledging the frustration. So here we should communicate well with the child, address to the child's needs, stay calm with the child, manage routine, ignore the tantrum, offer limited choices, distract the child. Like if the child is upset with certain activities, either the child can be engaged in a different activity or the environment can be changed. And positive reinforcement is must in these children to reduce the frequency of temper tantrums.
Perfect. So as Dr. Madhu told, these are the very, very effective strategies you can communicate to the parent and even do that. Either you should ignore the tantrum or you should distract the child. So this works out well in many of the situations, because if the child takes taking bath, then you can, if the child is showing a tantrum, you can take the child to a shower and do the bath, and this will change the tantrum. And as Dr. Kanimini told, so this is very important. So whether the child is normal between the tantrums or it is persistently having negative mood between the tantrums, and if it is lasting longer than 15 minutes and causing injury to others, then this has to be a red flag for that. So the tagline will be tantrums are immature regulation, not intentional rebellion. So that is very important. Tantrums are developmental. Frequency makes them pathological, as told by Dr. Madhubala. So going to the fourth scenario. So this is something which this is a 3-year-old child brought with a history of eating mud, chalk, paper for the past 6 months. Growth is normal, development is normal, but parents are worried. Is this Pica or just toddler behavior? So it is, I wanted to know from Dr. Rini whether this is a nutritional disorder or a behavioral disorder, whether you have any DSM criteria for this. What are the complications the pediatrician, because that is very important for us. Eating chalk, everything should not damage, because many parents, when they come for a routine consultation also, they talk about babies eating chalk, about the flakes from the wall, everything. When to intervene, that is also very important. Over to Dr. Rini for the answers.
Good evening, everyone. I first want to express my deep gratitude to IAP Tamil Nadu chapter and GDBP chapter for organizing this subspecialty CME and also providing me opportunity to be a part of in this panel discussion. So coming to Pica, Pica is defined as a persistent eating of non-nutritive and non-edible substances. So when it comes to the etiology, on one end, we have children who have nutritional deficiencies, which is most commonly iron and zinc, have come with Pica. What is usually postulated is when the children have some nutritional deficiencies, they try to get those nutrients from these non-nutritious edible substances. On the other hand, Pica is also seen in children as a learned behavior in children with developmental delays and deviation. It is commonly seen in autism, intellectual disabilities, and also in learning disabilities. Well, it's also we have to also rule out neglect of the child. That's one thing we always have to remember. So the etiology is multifactorial and heterogeneous, and also in the DSM criteria, it comes under the heading of eating and feeding disorders. So we cannot label as nutritional and behavior. It is a multifactorial etiology is present. Coming to the DSM-5 criteria, it is defined as a persistent non-nutritive ingestion of non-nutritive and non-edible substances, and the duration should be for a period of 1 month. Examples of non-nutritive can be anything from chalk, soil.
Just a minute. I'll mute it. Yeah, you can proceed.
Thank you. This behavior, eating behavior should be inappropriate for the developmental age, because in young toddlers and infants, we do commonly see mouthing behavior, which is a part of their sensory motor stage. So it should be inappropriate for that developmental stage. So after 2 years, we commonly make that diagnosis, and that behavior shouldn't be a part of their culturally accepted norms, because certain regions in Africa, South America, and even certain religious beliefs, they do eat certain non-nutritive things. Soil, ash can be ingested, so it shouldn't be a part of that norms. And if it is occurring with another mental disorders, it should be severe enough to warrant independent clinical attention. So complication is something which we have to prevent as pediatrician and also evaluate and treat. So this is very important to know what are the complications. One of the most common complication of Pica is poisoning or intoxication. Commonly, lead is commonly seen. Lead is usually seen as a pigment in paints. Even though recent paints don't have lead, or old paints and cheap paints they do use it in toys and certain ceramic, doing some ceramic pots. So we have to ask history, and based on the history, and also look for signs of lead poisoning. Usually we will have either a neurological sign from confusion, irritability to seizures. The spectrum, different symptoms can be present, and also GI symptoms can be present, like constipation, colic, and abdomen pain. The other second thing is infections and infestations. Since such child eats soil, fecal contamination can happen. And commonly toxocariasis is implicated, and also ascariasis. So we have to find out the signs and symptoms related to that. Another thing is GI complications. It can be anywhere from abdomen pain to symptoms of obstruction. In child with intellectual disability, if they eat hair, benzoate formation is common. The other thing is they can also present with dental abrasions and surface tooth loss. When to intervene is again the pica should be developmentally inappropriate, and there should be it should be frequent and it should be compulsive. And there is a risk of physical harm. It can be either from ingestion of any toxic substance to infectious agents. And any associated conditions like iron deficiency, anemia, intellectual disabilities, and autism. And again, it should impact the functional life of the child. So screening for both nutritional deficiencies and developmental delays is important. And also ruling out complications is important when it comes to pica.
Perfect. Right. As you told, it's a very common condition that DSM-5 have come up with a criteria for this condition. So, so we all pediatricians should be vigilant enough to ask for either the cause why this is happening. It is not either nutritional or developmental. And our second part, our role will be to treat the complications if something has happened because of this pica. When cravings go beyond food, look beyond nutrition. That's the first tagline for this case. And pica signals deficiency, development, or distress. So these 3Ds has to be thought of when you are encountering a child with pica. So moving on to the fifth case scenario where this is a common condition. A child comes to you, so the parent will say, only my child is saying abdominal pain every morning or headache every morning when he wants to go to school. And if the school day is avoided, he plays after the school hours is gone. In the daytime, he is normal. So this is a 7-year-old child refuses to go to school for the past 3 weeks, complains of abdominal pain every morning, symptoms of disappear on weekends. Academic performance previously good. Parents are confused. Is this drama or it's an anxiety or something serious? So Dr. Nimi will brief us on what are the underlying causes, what are the red flags you should pick up, what is the management, and finally we should know from Dr. Nimi, this is the problem of the child or the problem of the family or problem of the school system. Right. Over to Dr. Nimi. Yeah.
Thank you, sir. School refusal is actually a symptom and not a diagnosis. So it can be due to an emotional distress leading to difficulty in attending school, or absence occurs with parental awareness, which distinguishes it from truancy, where the parents will not be knowing that the child is not attending the class. And early identification prevents chronic absenteeism and academic decline. So coming to the etiology, it's actually etiology is widespread. I mean, I will start from the child. Anxiety disorders in very smaller children, I mean less than 4 preschool children, separation anxiety disorder is one of the most common cause. Social anxiety can be there because nowadays a lot of screen time is there for the children, and even normal children which we see in the OPD will have a social communication difficulties and poor eye contact and things like that. And generalized anxiety disorder, which is not very common, and mood disorder. Major depressive disorder is not very common in smaller children, but it is still it is there. Neurodevelopmental conditions like ADHD, which is a common case scenario in our OPDs, then autism spectrum disorder and specific learning disorders, because these children with SLD, unidentified children, will not meet the academic requirements, and then will have confusions and difficulties in the school and will cause school absenteeism. They will refuse to go to school. Psychosocial factors are very important. Increase in family stress, increase in the number of working mothers, conflicts in the family. Overprotective parenting is one of the most common cause now, because nowadays only 1 or 2 children are there in each family, and the parents are very much protective about their children. And whenever they say very small complaint like some pain here and there, they'll say don't go. And even for the cold, the child will be kept in school, I mean, in home for so many days that the child will take that as a habit. Then parental anxiety is what I've explained. Then secondary gain. That is, I think the last 2 years I've seen this as the most common reason in children aged 5 to 10 years. Whenever they have a problem now, in the last 2 years, we have a lot of gadgets in the home after COVID. So whenever they have a problem, they can sit in this at home and use these gadgets, the TV time, the mobile game, and all. And we have a lot of cases in the adolescent age also with school refusal to get the screen time and this have these games and all. School factors like bullying, academic pressure, then harsh discipline, then transition either to a new school or changing of the teacher, all can also be reasons for school refusal. So a detailed, approach to that, a clinical presentation will usually be most commonly the morning somatic complaints, headache and abdominal pain, then crying, tantrums, sleep disturbances. And sleep disturbances as in like the child will not sleep properly in the previous night, saying that the child doesn't want to go to school. And that will upset the parents also, and that will ultimately will result in school absenteeism. And there can be school performance decline also. So assessment, the first and foremost thing is to rule out any organic causes. So chronic diseases, GI pathology, sleep disorder, this chronic leg pain and all. I mean, whenever we say this is growing pain and all, should be ruled out. Other conditions like leukemia and chronic arthritis should be ruled out. So after ruling out an organic cause, you should go into a detailed developmental and psychosocial history, screening for other comorbidities if required, and we should take inputs from the teacher and the school also. I mean, how the child is at school, and also functional analysis, what maintains the behavior, if there is secondary gain for that. So management is always early intervention, because if we allow this, I am seeing children who is not going to school for months, which is not ideally advised. I mean, parents should be addressing the problem. If they cannot address, they should be, they should be advised for a proper evaluation. It may not be a normal pediatrician, because they will not have time for evaluation of all these things. So should be properly evaluated by a developmental pediatrician if the school absenteeism is more than 2 weeks without proper organic reasons. And gradual but prompt return to school and multidisciplinary coordination. So interventions include cognitive behavioral therapy, graded exposure plan. I mean, if it is an anxiety and all, the child can sit in the school for 1 hour and then 2 hours and things like that. Then parent training is the most important factor there. Then avoid reinforcing this absence. They should be firm enough, gentle but very firm on stance while dealing with these children if it is a psychosocial problem. Then school accommodations, like you can talk to a teacher who is understanding. You can find some teacher who is understanding and who can actually talk to the child and make the child comfortable at school and things like that. And if there are bullying and all, to monitor those things, can identify some teacher and entrust the child to the teacher. And drug only if needed, and in cases of generalized anxiety disorder and things like that, after ruling out all other conditions. So coming to the absolute red flags, if the child has a suicidal ideation or self-harming behavior, there are features of severe depression, school avoidance more than 4 weeks with total absenteeism, and panic disorder with functional impairment. And this panic disorder is also seen in children, and that actually scares the parents. And that also can, if we have a child who is not going to school for the last 2 years, and we have tried everything possible, but even the parents are not very compliant with, because that is another thing. They get very upset seeing the child showing somatic symptoms, and they'll get carried away with that. So suspected abuse, and that should not be ignored. Any child who has a school absenteeism, either boy or girl, should be evaluated for suspected abuse, detailed history, and even physical examination if needed. And psychotic symptoms if present, and sudden personality change also should be, should have proper referral to a developmental pediatrician. So the key take home is school refusal is mostly anxiety driven. Always screen for neurodevelopmental disorders and avoid prolonged homestay, even for a fever, cough, or general diseases. Homestay is advised only for the needed days. It's not like that will cause laziness in children. And collaboration between pediatrician, family, and school is critical, and early structured intervention improves the prognosis.
Yeah, so excellently briefed by Dr. Nimi Joseph. So we should know that school refusal is a symptom. So as we deal with fever, not treating with the paracetamol alone for 5 to 6 days, we should find out the root cause analysis why this school refusal as a symptom is occurring. Either the child factor, it can be either physical or psychological, or the problem is with the school. The school, there is some bullying, or the school teacher is not good with the child or something like, or it is the family which is at fault. So either of the three can be or it's an unmotivating family or something like. So either the family factor or the school factor or the child factor. So school refusal is rarely laziness. It is often a silent issue. So you should always look into what the silent issue is there in the child. Early return school is the best medicine, as stressed by Dr. Nimi Joseph. You should not prolong this, and you should make the child. There are kids who don't go to school for 2 months, then switch to next school. There also they go for about 2 months, then they don't go to school. So early return to school is the best medicine rather than going for other medications. So going to the next case scenario, which is conduct disorder. So this is a 10-year-old child presenting with repeated aggression, lying, stealing, and school suspension. Parents say the child is out of control. Is this a bad behavior or a psychiatric disorder? What is the diagnostic criteria, and what should be the comorbidities and management? Over to Dr. Kanimuli. Yeah.
Yes, sir. So all these behaviors occurring once in a while may be a bad behavior, but when it is a repeated pattern of behavior, then we consider a conduct disorder. So we have a clear-cut DSM-5 diagnostic criteria for conduct disorder. The definition is there should be persistent, repetitive pattern of behavior. Two things to be considered. There should be violation of the basic rights of others and also violation of the social norms. There is 15 criteria, which is classified into 4 major categories, and 3 or more of the following should be present in the past 12 months and 1 or more should be there in the last 6 months. So first is aggression with people or animals. It can be a physical cruelty, bullying, fighting, even using weapons, threat, and force sex. Destruction of property, deliberately doing it like a fire setting or causing serious damage to it. Deceitfulness or theft, either confronting or even without confronting them, shoplifting, and serious violation of rules like non-adherence to curfews, even under 13 years of age, and 2 or more times they are staying away overnight, and truancy in children less than 13 years of age. And it should cause a significant impairment at school, work, and social functioning, like we say for any psychiatric disorder. And if more than 18 years of age, then consider antisocial personality disorder first. This is again classified as childhood onset, less than 10 years of age, which is the most common type seen in 70%. And sometimes 30% can have an adolescent onset. We also have to see if they have limited pro-social emotions. Like 1 of the 4 have to be present. There should be clear lack of remorse and guilt, lack of empathy for the emotions of others. They are unconcerned about their performance in school or other workplaces. And there is shallow or deficient affect. They don't have any emotions at all, even for the consequences that they face for their behavior. So this is most of the times seen around 2 to 10% and common in males, especially in families that have internal conflicts, any domestic violence, those who have undergone any physical or any sexual abuse in childhood. Coming to differential diagnosis, most common differential diagnosis is an oppositional defiant disorder. This is seen in slightly younger children. It is usually arguments with authoritative figures, but there is no intentional violation of rights or the social norms here. The other common differential as well as a comorbidity is ADHD. Here the aggression is because of impulsivity of ADHD, but rather than causing intentional harm to the others. And common mood disorders like a disruptive mood dysregulation disorder or a major depressive disorder, and in bipolar disorders. So here it is mainly irritability, temper outburst, and in bipolar, the aggression is during mania, and nowhere it is an intentional harm and violation of the rights of others. Adjustment disorder, it is commonly a response to some stressor, but if you're going to eliminate the stressor within 6 months, the aggression will resolve. And substance use, even here, the aggression and the bad behavior is seen during the periods of intoxication or withdrawal rather than a consistent pattern of behavior. And coming to the comorbidities, like we saw, most of the differentials can also be a part of comorbidity, which can worsen the prognosis in children. Most common comorbidity is ADHD, seen again commonly in boys in 16 to 20% of the individuals. ODD, that is oppositional defiant disorder, like half of them will satisfy the criteria of ODD too. And most of them with ODD can grow up to develop a conduct disorder also. And this comorbidity increases the risk for substance abuse, which again is going to be resulting in worst prognosis. And they also have high chances of mood disorders developing, and 45 to 70% with conduct disorder will go on to develop antisocial personality disorder. So coming to the management, so management is mainstays in non-pharmacological management. So we saw there are a lot of problems in the families that can predispose to the development of conduct disorder. So family support, school support, and intervention for the child all should go hand in hand to bring the child out of the conduct disorder. So it is treatable. We have to tell the parents it is treatable. So non-pharmacological parent management training is the mainstay of management. So we'll have to tell the do's, that is consistent discipline, consistent parenting, and also telling them that is positive reinforcement for the good behavior. And don'ts is, we don't label the child as bad, don't use punishment for avoiding the behavior. And coming to medications, so medications are only for treating the comorbidities and the aggressive behavior of the child, and there is no medicine that is going to treat conduct disorder as such. Studies have shown that we can use risperidone and also psychostimulants if there is associated ADHD, that is a methylphenidate and atomoxetine. And some studies have shown even the use of clonidine can help in reducing the ADHD in association with conduct disorder. So that is non-pharmacological treatment. As I already told, parent management training is the most important. And also for the child, we have to offer behavior therapy. And if it is a school child, we can offer cognitive behavior therapy. It can be an individual therapy or a group therapy. And also school support is very, very important.
Perfect. So we have many parents telling us this, my child is, so they may have that shyness in expressing us to us also. When the child is stealing others' pencil box and bringing to the home or something like that and all. So very difficult to counsel them. So how to manage. So Kanimuli has briefed it. So either it can be part of some other disorder, or we need to work with the child. The parent counseling is very important, because opposition today may become antisocial tomorrow. You need to intervene early, and your firm boundaries, early action will create better future. So this is the tagline of this discussion and this scenario. So you must have seen such scenarios, parents explaining that this scenario, the gratification which the child is getting by cross-legging their limbs, or such scenarios where the child is rocking the pelvis against the bed. So such scenarios, we call it as childhood gratification syndrome. And this is a 2-year-old child with recurrent episodes of leg crossing, pelvic rocking, preserved consciousness, and interruptibility. Previously suspected to have seizures. So, Dr. Madhubala, so how will this present, and what are the differentials, and how will you manage these children?
So masturbatory behaviors are not uncommon in children, and childhood masturbatory behaviors are active self-stimulation of genitalia in a prepubescent child and may be reported as early as in infancy. And the etiology of this is basically to attain pleasure. So it has been usually addressed as gratification disorder and infantile or childhood masturbation. So the presentation here, the child will be so the presentation here will be stroking the genitalia with fingers, hands, or everyday objects like toys, as we saw in the video on the bed, or using a pillow, associated with twitching of lower limbs for several minutes, with or without jitteriness, diaphoresis, or facial flushing. So the differential diagnosis here, unlike in seizure disorder, the childhood gratification syndrome is distractible. The seizure disorders are abrupt and spontaneous, whereas gratifying behaviors are relatively slow to start and voluntary. Movement disorders like paroxysmal dystonic choreoathetosis can also mimic as self-stimulating behavior. Motor tics, stereotype behaviors like hand fisting, grasping, or genital manipulation, or holding the objects with both the hands, lip smacking, all those stereotypical behaviors can also be mimicking childhood gratification syndrome. Local pathologies like abdominal pain, peritonitis, vulvovaginitis, UTI. So these symptoms can also have produce discomfort in the child, where the child can attain an abnormal posture, and retentive posturing in a child with associated with perineal tightening, whereas grunting, flushing, where the child withholds stools. So they can also show the self-stimulating behavior. And repetitive behaviors like in children with intellectual disability and also autism spectrum disorder, the child can mimic the childhood gratification syndrome. So evaluation, first we should know the episodes of genital manipulation by a child, as we discussed, rubbing or stroking the genitalia, twitching of the limbs, and whether it is voluntarily suppressible. If yes, we'll have to see whether the child is having perianal rash, scaling, or pruritus. If so, then dermatology consultation should be sought and treat accordingly. And if voluntary suppressibility is absent, then we should find out if there is lack of awareness, or whether it is non-distractible during the episodes, or inability to recall, abrupt onset and offset. So video EEG should be done. Brain imaging, neurological examination should be done to rule out seizures. We should find out whether male preponderance, paroxysmal dyskinetic choreoathetosis, or any abnormal movement disorders like motor tics, and family history, positive family history is there. Even in such cases, video EEG should be done, brain imaging, to rule out paroxysmal dystonic choreoathetosis. If the child doesn't have any of these symptoms, or if the symptoms is persisting, we should rule out other possibilities. And if the child has, we should find out if the child is having history of child sexual abuse, abdominal pain, UTI, tics, retentive posturing, intellectual disability or autism spectrum disorder, or compulsive sexual behavior. So management, the first and foremost is destigmatization, because parents have, in conservative societies, it is very difficult for parents to take the child outside to a gathering or address the child's difficulty. So first we should educate the parents, tell them what is childhood gratification syndrome, why the child is doing this, and what are the other things that has to be done. So parental reassurance is very must, and psychoeducation is crucial in these parents. But here the parents should be told that if the child is exhibiting the behavior, the parent should not provide any threat to the child or punish the child. The child should be distracted in certain activities where the child can reduce the attempts of the childhood gratification syndrome. Behavioral training and habit reversal techniques should be done, and medications can be used if psychotherapeutic approaches are not supporting the child, and if the symptoms are problematic, medications like risperidone along with behavioral therapy is a must for these children to support. And also aripiprazole, escitalopram, and mirtazapine drugs have also been tried in these children.
Perfect. So, as Dr. Madhubala told, parents feel stigmatized. Even to tell to us, they will send everybody outside, or the child also outside and others outside. Then they will tell that this child is having this behavior. What is that? They may even interpret that this child is having some itching sensation in the perineal area, or the child has got some UTA or something like that. The misinterpretation. So, not seizures. It's not a sin. It's just self-stimulation. Is the assurance which you are going to give the parents, and awareness prevents over investigation. So coming to the last scenario, which most of our friends who come to our clinic, so climb on the couch, they're doing all sorts of nonsense. So this 5-year-old boy is brought by parents for poor school performance and behavioral concerns, easily distractible in the class, always disturbs other children, frequently leaves seat and wanders, interrupts teachers and peers. Can this be ADHD in a 5-year-old child with this history, or what additional history do you need? What are the comorbidities, and how are you going to manage the child, Dr. Rini?
Okay, sir. So this is a 5-year-old boy with the following complaints of poor school performance and other easily distractibility, frequently leaving seat. So we have symptoms of inattention presenting as poor educational performance and hyperactivity and also being easily distractible. Hyperactivity is manifested as frequently leaving seats and wandering, and also impulsive behavior which leads to interrupting teachers and peers. So can this be ADHD? We need ADHD is diagnosed based on DSM-5 criteria. So with these specific symptoms is not enough to diagnose ADHD. So we need more history related to whether it is present in 2 or more settings. Having it on usually in young child, it's usually the school and the home environment. The child should have persistent symptoms in all of these sects in all the in both the home settings, in home and the school. And also it should be persistent for more than 6 months. Again, getting history both from the parent and teacher would be more beneficial. There are a lot of rating scales are present. And also just with the symptoms alone is not enough. We also know whether there is a functional impairment for the child, either in academics or in relationship with the peers, relationship in the family and siblings. So some functional impairment has to be present. And we also have to rule out other medical and other conditions which may lead to hyperactivity, and also some genetic conditions may present with hyperactivity. Example is Fragile X. Certain drugs may cause hyperactivity. So all of these has to be excluded before making a diagnosis of ADHD. Again, coming to diagnosis is based on DSM-5 criteria. We have 9 symptoms in the inattention and 9 symptoms in hyperactive behavior. More than 6 has to be present of the 9 in age more than up till 16 years, both in inattention and hyperactive impulsive behavior. Again, the age of onset should be before 12 years. And it should be present in 2 or more settings. And the symptoms we have to diagnose only after ruling out other disorders. It can be other mood disorders and drugs. And there should be a definitive functional impairment. Only after, based on this, we can make a diagnosis of ADHD. Coming to the comorbidities, again, it's very important to screen for comorbidities in ADHD, because in ADHD, comorbidities are a rule rather than exception. Around 60 to 90% of the children and adolescents have comorbidities, which will again impair their functions. The most common is the neurodevelopmental disorders, especially learning disabilities and autism spectrum disorder. Along with that, tics are also commonly present, and developmental coordination disorders are also commonly seen. And coming to the internalizing disorders, depression, anxiety, bipolar disorders are common. In externalizing disorders, we do see ODD and conduct disorders very common. Followed by disruptive mood dysregulation disorders and intermittent explosive disorders. And also others are also present. Commonly, we have to screen as sleep disorders, eating disorders, and substance abuse, especially in adolescents and young adults. Coming to management, the management depends on the age of the child and also severity, and also the presence of coexisting comorbidities. In a young child, preschool age, 4 to 6 years, we usually start with parent training in the behavior management. It's very important to train the parent to manage the behavior. One thing is we have to realign the parents' expectations, because we cannot, the hyperactivity and attention will not improve immediately. And also parents have that perception that child is extremely naughty or is lazy, he's stubborn, he doesn't listen. These kind of labeling the child should be avoided, and we have to counsel the parents about how the brain of the ADHD child works. And then we also have to give the definitive ideas of how to manage a behavior, how to give a positive reinforcement when there is a positive behavior, and not to reinforce a negative behavior. We also have to make an environment modification in the house or in the school to prevent distraction, give a structured routine, to offer a star chart for positive behaviors, and also give visual schedules and prompts to do the tasks. And we also can do a behavioral classroom intervention to again reduce the distraction. The child can be placed in the front row, and teachers can give frequent prompts so that their attention can be managed, and they can reduce the cognitive load of the child by giving easier works for these children. And also bigger task, they can divide it into a small subtask and provide the child. Classroom accommodations, again, we can increase the time so that they can have extra time to finish their activities and tasks. And also maybe timers can be provided for these children. In school age, older kids, usually it is recommended to start drugs along with this behavior management. And again, these behavioral classroom interventions can be given. Cognitive behavioral intervention will work when the child has other internalizing behaviors and externalizing behaviors. And a definitive individual education plan also should be provided for this age group. Coming to the drugs, we have two groups. One is stimulants and non-stimulants. Usually stimulants are considered first line. Methylphenidate and amphetamines are the two drugs available, but amphetamine is not available in India. Non-stimulants, we have atomoxetine, chloride, and guaifenesin. Before starting any drug, we have to take a clear history. We have to record the anthropometry of the child, rule out seizures and sticks, because stimulants should not be given in children with seizures. We have to ask the sleep, appetite history, and also document the cardiac history, especially for stimulants. If needed, we can do an ECG, but a clear-cut cardiac history has to be documented before starting stimulants. And we have to explain the clear side effects of any drugs before starting to the parent, and also if the child is an adolescent or young adult.
So, well explained by Dr. Rini. Just hyperactivity alone doesn't qualify the child as an ADHD. So, at least in two or more situations, at least for 6 months, and at least the child should have 6 symptoms. So, that is the criteria to say that. And the important one is that should have some functional impairment for the child. Without any functional impairment, just hyperactivity in either the school setting or the home setting doesn't qualify the child as an ADHD. And the preschooler, you can manage with accommodations and therapies, but in the school age children, along with therapy, you may need medications which may be either for long period. So ADHD is not bad parenting, it is neurobiology. If untreated, ADHD affects the lifetime trajectories because the child will not be able to perform in the school setting, in the college setting, in the family setting, in the workplace setting. The child will not be able to perform. Early recognition rewrites the academic futures. Channel the energy, don't suppress the child. So we are just ending this session. Children are not born with an understanding of the rules of acceptable behavior. They have to learn them and need the adults' help to do this. I thank my esteemed panelists, Dr. Nimmi, Dr. Madhubala, Dr. Kanimoli, and Dr. Rini for excellently crafting the answers for all the questions from my side. Thank you very much for your patient hearing. We are open for answers. Thank you very much.
So, in case of ADHD children who started on drugs like methylphenidate and clonidine, how it is safer to how long to give the drugs to the child?
Rini, you want to answer?
Sir,
regarding drugs, madam.
Yes, sir.
Regarding methylphenidate.
How long to give?
Yes.
Sir, we have to continue drugs and behavioral intervention, and we can give a drug-free holiday. We can give a trial. That is not immediately after the child settles and the child learns how to manage his daily functions. whether it's in home or his academic works. And then we can slowly try to taper and give holidays, and then carry on based on how his life is, functional life is. But he may need in between, when there is excess stress in his the child's life in the adolescent stage, when there is a change in the environment, the child may, when high stress environments, may need an excess drugs at that time. But it has to be based on that situation, particular situation.
Right. So, as Rini told, it's right. So, child, see, what I have heard from Dr. Jayantini, because we are all deal with only children. So, Madam has exposure to both adults, adolescents, and adults. So, she told, so this is like treating congenital hypothyroidism. So, you need the drug probably for the adult to get controlled of his impulsivity, hyperactivity for long, because if the hyperactivity situation is there in the family during the family life, he can have issues with the family. In the school area, in the work setting, he can have family in the works when the problems in the work setting. So what people have to do is, as Dr. Rini told, you can stop at some time, so, and then if you need it, we have to restart. So there is no clear-cut guidance that you have to stop by this period or something like. You can tune the dosage, or you can modify the drugs accordingly. That's the.
I just want one example of behavioral intervention, Dr. Rennie.
For ADHD, sir?
Yeah, correct.
Sir, the child will avoid usually complex tasks or any task which the child finds it difficult because of inattention. So we can divide it into, like, if he has to write a big paragraph, we can, it should start from the early stage, taking the stationery, bringing the books, staying in one place in the table, and either copying from a book or reading and writing. So this whole thing should be divided into subtasks. So you should give prompts. Yes, get your stationaries, then get your books, sit in the table, start writing. We can give either visual schedules or keep a timer. Initially, these prompts should be guided. You should guide them and slowly withdraw these prompts, and make the child fully independent. Without any prompts, the child should start doing all these things. If it is not given, the child will have inattention and will delay everything, from taking the books to writing. So that we have to give tiny prompts and reduce the cognitive load for that child, sir.
The problem is with many parents find it that to make the child to sit at one place is a tough task.
True, sir.
They don't obey the orders. That is the problem. If I ask them to get the book, make them sit, take the pencil, they never do it. They are in their own play.
Okay, sir.
How to?
Sir, one thing is, less than 6 years, they are preschoolers. We don't have to give them a lot of books. Education at that time is very simple. After 6 years, we do have support of medications. Or expecting, that is why we have to realign the parents' expectation that less than 6 years, we can take a little bit of hyperactivity as normal and let the child play. But very important things they have to do, especially their daily activities of living, like brushing, bathing, that they should not delay for too long. This dressing, everything.
Okay.
Education-wise, after 6 years, we can help.
Okay. Thank you. Thank you.
So it was I think the panelists have answered in detail everything. So, is there any more questions?
Very well done, moderator and all the panelists.
Yeah, thank you, Dr. Vichu.
Just one more question. Actually, yes. For palate spells or that breath holding spells, in Nelson there was a mention earlier that carotid massaging, pressure over the eyes, do they work?
So actually, ocular compression test they use to diagnose the palate spell. Like we give a compression for 10 seconds, it induces bradycardia and can reproduce the spell. I'm not sure for management purposes. Because even the studies, they show that you can do ocular compression while doing EEG along with cardiac monitoring to diagnose the spell, sir?
I just got one question to all the panelists and the moderator and also Dr. Naveen and other people. The screen time, people do say that, no screen time, but they do say the limited screen time until 5 years. Though they say that no screen time for less than 2 years, but still I strongly disagree with that. There shouldn't be any screen time even until 6 years. They say the immediate screen time for 30 minutes for children from 3 or 5 years. I'm not sure whether how do you agree with this? Can you just give your comments, please?
See, what they say is less than 2 years, it's only screen time is only for using video calls with the relatives or some Zoom meeting with the kids or something like, so they can use the screen time. 2 to 5 years, they can use the screen time, but it should be mostly academic or it should be assisted by the parent. The parent has to also to sit with them, and that's the screen time guideline. So more than 5 years, it's a different criteria. So that's the screen time guidelines which I know.
The only thing is, I do understand. The only thing is 2 to 5 years is also a very true, very important formative years for children. And at that time, as like less than 2 years, they shouldn't be exposed to screen at all. And that's the time they need more and more human interaction. Whatever interaction they need, it should be a sort of, a direct interaction rather than through screens.
No, guidelines say there is no screen time till 2 years. You are right. You are
No,
right.
no, even until 5 years, I'm talking about. Even from 2 to
5
5.
years. See, what they say is until that first 2 years of life, they learn the vocabulary. That vocabulary should not be learned from the screen. Once they learn that this is the dog or this is the cup from the screen, and that will be very difficult to translate it to the real life of the dog or the cat. So that's the reason they don't advise screen at all till 2 years of age, because that's the learning phase between 9 months to 2 years when the parents teach that, okay, this is the cup, the things in the surroundings, that this is the cup, this is dog, this is spoon and everything. And they should learn from the real environment that this is the cup and this is the spoon and this is biscuit and this is milk, rather than from the screen sitting alone and learning that. So they will not be able to translate it to the real life. So once the vocabulary of about 100 to 200 words is learned till 2 years of age, then it is okay to convert what I say, expose to screen with assistance or something like. So that's my understanding of the limitation of screen.
But talking to people, I do think in near future, I think they may even extend until 5 years of no screen time. Let us see. Thank you.
I think even classrooms have become smart classrooms with
Yeah, I know
more
that.
and more the
That's what I'm
board
trying to
switching
say.
over to screen.
No, that's what I'm trying to say. As a pediatrician, I think in near future, I think we should come up with some sort of guideline because in many countries, Western countries, Australia, New Zealand, they have banned the social media, this online, all this class, even until later childhood. At least for 5 years, until 5 years, we should really tell them, we should come with some ideas to ban completely the screens for these children and until 5, because those are the crucial years when they should learn everything from the children, actually. From the human interaction rather than anything to screen. Subbu is saying something, I don't know. Thank you.
Subbu wants to say something. Subbu, yeah.
Good evening, everyone. Sorry, I was traveling, so I was not able to really comment on a lot of things. This is a very interesting topic that MSV has brought up. Sir, MSC, sir, there are two important aspects. One important aspect that we have to look at is screen time, whether it is passive screen time or whether it is collaborative screen time. When it is a passive screen time, it is something that can definitely be avoided at all ages, where the child just passively looks at the screen. There is nothing that is coming back or going. There is no back and forth interaction between the what's happening in the screen and the child. When there is collaborative screen time, where there is a parent, there is a human in the loop between the child and the screen, the learning becomes the priority. So I think it is more about how the screen is used rather than screen itself. I think, and there is one more point that very rightly pointed out by MSV sir. I think European countries, some countries, Netherlands or some country I read, they're reverting back to books because of screens not giving the multisensory input that a child needs in early age.
That's
so
right.
They are reverting back. Yes,
And
correct, sir. So
Japanese study has clearly mentioned.
Yes, correct.
5 years
so there are a lot of studies that are coming up.
screen.
Yes, sir. This is one area where we are looking at a lot of aspects, but screens are not the villains that we are projecting them to be. It is how the screens are used that is the villain.
The only reason is even that time has to be used for human interaction. That's the point.
Yes, sir. At every point of time, when you use, there has to be a human in the loop. Without a human in the loop, it becomes a passive screen time. So that is how
But then
it is going to come out. So let's
almost
wait for the
all the
studies.
time,
Yes.
I'm sorry to interrupt, but then almost all the time screen is being used to engage the child. And I mean, as a substitute for a parental or a caretaker care. And what I've noticed is the most effective intervention in all these neurodevelopmental disorders is stopping screen.
Correct.
More than this therapies, more than this anything, medicine, stopping screen really works. And whenever we see children for reviews in the OPD, if they are still using the screen, we'll understand that. So stopping screen or limiting screen usually doesn't happen because all these will give for 10 minutes.
Yeah.
The child will throw tantrum and then it
Exactly.
will end up a long time screen time. So
I think it's very
as
good.
sir mentioned,
Yeah, it stops.
till 6 years, children should not be
No,
given
we will
screen.
be able to limit screen over the older children. They understand. These younger children will
Yes.
never understand. The only option is stop screen. That's it. That's the only thing it works. When there's a human being there, why they should use the screen to teach them? That's my point. The human can teach better than the screen. I mean, that's my point.
Exactly.
I was worried I missed the screen time scenario because of want of time. Now, MSV, you have.
Because I tell you honestly, this is real problem. Even in my
yes,
gastro
definitely.
clinic, a 18 months old child, as soon as they come to give the mobile, the boy just hitting like the head like anything. They couldn't do anything. Just like the moment they remove the mobile from him, he just threw the tantrum for 10 minutes non-stop. They couldn't do anything.
Initially, it's only YouTubes and so such things, and then it switches to gaming, then it switches to social media. So that's the hierarchy of things which happens with children, and probably you have to put a something for these children. And there is a question from Dr. Maidili: what are the simple observation steps given to the parents, those having the KG children? Anybody wants to take this, panelist?
Parental time is the most important thing in preschool, and I mean, at least up to 8 years. The time spent with the children is the most important thing in their preschool, in their learning, behavior, and accomplishments. So, I mean, how much of a busy we are, we should be able to spend quality time with our children. So, I mean, even now, if you look at this, I'm sitting in the middle of my children, and there is no screen, though they are screaming there. But it is a distraction, but still we will have to manage it. They have come at least like 10 times here asking for so many things. So though we have a lot of engagements as different professionals, quality time with the children and the preschool, I mean pre-writing and writing time, at least 1 hour a day for academics is very important. Never share your gadget with your child. If you give phone once, it is their right. So never share that. If you want to show screen to a child, keep a fixed time, like 30 minutes. And at the end of the 30 minutes, if the child is not stopping, there is no screen for the coming 1 week. And that really works. They are listening to it.
Correct.
So,
So good parenting from your side now, as of. So I can understand the question also asks for what observation I should do for a KG child, if I am right, Dr. Maithili. So I would suggest that the social behavior of the child in the classroom, that also has to be inquired with the classroom teacher or somebody if you are sending a child to the KG class, because there are kids who come to me, the teacher has picked up that this child is not language appropriate. So the first question I will ask is the child socially appropriate also in the classroom? So that is very important, because until 2.5 to 3 years they are only with the family, where the family members are there. After 3 years they are going to be put up in a classroom where there are 15 children. Are they social play is there and socially engaging in all the activities? That's the first observation step I will ask the parent to look into if in a KG child. So hope I answered your question. So if you are no more questions, we'll end up this 60 plus 60 plus another 20 minutes, 160 minutes of developmental pediatrics, which was well crafted and well done by all the 4 panelists and the 2 speakers. Dr. Jagadish, you wanted to say something before, and Dr. Narmada, if you are there, if you want to say something.
Awesome.
Or we'll ask Dr. Madhubala to post the vote of thanks and then finish it off. Yeah.
Dr. Somasundaram, it was a very, very interesting
Yeah.
session.
Yeah. Sound, volume.
Yeah, it was a very interesting session on a very common thing which we are seeing in that is why we had around more than 70 to 80 participants at any point, and then in YouTube also. So that is really great that people, the thing is that more than infections now, the chronic diseases are becoming more, like allergies and the growth and development. So it's very nice to listen to a very practical, you have made it very case based. I really appreciate Dr. Naveen Jain, Dr. Vivek and the panelists who brought in all the practical cases which we are seeing in the OPD. The only point is we do not have much time for that, and we actually just that when the patient is leaving after asking all for the respiratory and infections, they will ask this question. You have given very practical points on how to manage in our OPD. Kudos to all the panelists. I'm very sure most of our members will be benefited by these practical suggestions.
Thank you, Terry. Thank you very much for the appreciation to all the experts today. Over to Dr. Madhu for the closing remarks and vote of thanks.
Yes, sir. So as we come to the end of today's program, it is my privilege to propose a vote of thanks. I would like to appreciate our heartfelt gratitude to our respected chairperson, Dr. Jagdish Kumar, and moderator, Dr. Somasundaram, for guiding the sessions with wisdom and expertise. A sincere thanks to all the distinguished speakers and panelists for sharing their valuable knowledge, clinical insights, and practical experiences. A special thanks to all the delegates who joined us virtually for your active participation. Once again, thank you all.
Very sure Nimi's kids will be very happy to be associated. Dr. Nimi's kids are waiting for her to complete the session, so they will be happy about the same.
Yeah, thank you everyone.
Thank you,
Thank you.
everyone.
Thank you. Thanks a lot. Good night.
Yeah. Sorry, it extended by few minutes because of the session was interesting, and so
it was
sorry for
planning.
being all the panelists and the delegates. We are always there on YouTube, so people can hear from us for years the message which we have given. Thank you very much. Thank you all the panelists, senior people, Dr. Manohar, Dr. Jagadish, and all the office bearers and delegates who are on this platform. We'll catch up for the special CME, specialty series CME next March. I think it's 29th, if I'm right, Dr. Narmada. Your allergy one, right?
Yeah, 29th is the last.
Narmada wants to do allergy chapter symposium. Right. Okay. Good night, sir. Thank you very much, sir.
Good night.
Good night.